Welcome once more to this YouTube channel. Kindly subscribe to this channel. The topic is Applied Anatomy of the Head, Part 1. Applied Anatomy of the Head, Part 1. I'm going to start right away with head injuries. Head injuries are a major cause of death and disability. The complications of head injuries include hemorrhage, that's bleeding, infection, and injury to the brain and cranial nerves. There is disturbance in the level of consciousness, and this is common with head injury. In about 10% of all deaths in some parts of the world, the cause is head injury, and you have half of traumatic deaths involving the brain. Head injuries occur mostly in young persons between the ages of 15 and 24 years. The major cause of brain injury varies, but you have auto accidents and motorcycle accidents being common causes. Men are affected 3 or 4 times more often compared to women. Now let me talk about head injuries and intracranial hemorrhage. You can have extradural or epidural hemorrhage, that's bleeding, and this is usually arterial in origin. Blood comes from torn branches of the medial meningeal artery, and this blood collects between the external periosteal layer of the dura and the Calvaria. This bleeding can actually come from a hard blow to the head, and you have an extradural or epidural hematoma forming as a result. There is usually a brief loss of consciousness. Then you now have a lucid interval of some hours afterwards. What happens later? After this, you have drowsiness and coma. That's the coma is usually due to profound unconsciousness. There is compression of the brain as the blood mass increases, and this brings about evacuation of the blood. So there's need to evacuate the blood, and there is also need to occlude the bleeding blood vessel. When there is you note that a dural border hematoma is usually called a subdural hematoma. So hematomas at this region are usually caused by extravasated blood that splits open the dural border cell layer. The blood does not collect within a pre-existing space per se, but the blood creates a space at the dural arachnoid junction. Dural border hemorrhage usually follows a blow to the head. When there is such a blow, it ejects the brain inside the cranium and injures it. The trauma, whatever is causing the trauma, might be trivial, and it's possible that the individual has even forgotten that he or she had such a trauma. Dural border hemorrhage is usually venous in origin. That's the bleeding comes from a vein, and it usually results from the tearing of a superior cerebral vein, and the tearing occurs at the point where the vein enters the superior sagittal sinus. Subarachnoid hemorrhage is an extravasation, that's escape of blood. Such blood is usually arterial, and this blood escapes into the subarachnoid space. Most subarachnoid hemorrhages result from rupture of a circular aneurysm. This is actually a sac-like dilation on the side of an artery. Such aneurysm could be, for example, aneurysm of the internal carotid artery. Some subarachnoid hemorrhages are associated with head trauma and involving cranial fractures. When there's head trauma and there's cranial fracture, and you have cerebral lacerations. Bleeding into the subarachnoid space results in meningeal irritation. You have also a severe headache. There could be stiff neck, and often you have loss of consciousness. What about headaches and facial pain? Headaches and facial pain. Headaches and facial pain are common complaints. Usually, the cause could be due to a benign lesion, usually associated with tension, fatigue, mild fever. But at times you have headaches indicating a serious intracranial problem such as a brain tumor. Headache could also be due to a serious issue like subarachnoid hemorrhage or meningitis. You have neuralgias, that's pains that are characterized by severe throbbing or stabbing pain, and this pain occurs in the course of a nerve. That this pain is actually caused by a demyelinating lesion. Such neuralgias are common causes of facial pains. When you hear of facial neuralgia, it's actually it's usually diffuse painful sensations. You could have localized pains that are referred to with specific names, like when you have an earache, we say it's otalgia, and when there's toothache, we say it's odontalgia. So you really need to have a good knowledge of anatomy of the head to understand the causes of headaches and facial pain. Now, let me talk about dural origin of headaches. The dura is sensitive to pain because it's related to dural venous sinuses and meningeal arteries. At that point where the dura is sensitive to pain, and particularly the sensitivity is profound where there's dural venous sinuses and the meningeal arteries, such that when you have a pull on arteries at the cranial base or veins near the vertex where they are pierced by the dura, you have pain. And distension of the scalp or meningeal vessels is a cause of a headache. Many headaches are dural in origin, like the headache that occurs after a lumbar spinal puncture that is done to remove a cerebrospinal fluid. Such headaches are thought to result from stimulation of sensory nerve endings in the dura. When cerebrospinal fluid is removed, the brain sags slightly, and this pulls on the dura, and this might cause a headache. So because of this, patients are asked to keep their heads down after a lumbar puncture to minimize the pull on the dura and reduce the chances of getting a headache. Now, fractures of the skull. Imagine the skull. The skull is like an elastic sphere completely filled by semi-fluid material. So when you have a violent blow on the skull, it gives a splitting effect, and this splitting effect commences at the site of the blow and tends to travel along lines of least resistance. So the base of the skull is more fragile than the cranial vault, and it's commonly involved by such fractures. The petrous part of the temporal bone forms a firm and rarely involved buttress of the skull base. The fracture line passes through less resistant areas, particularly the middle cranial fossa, the pituitary fossa, and the various basal foramina. When there is a localized severe injury in an adult, you could have a depressed comminuted fracture. For the infant skull is more elastic, and such is localized severe injury results in a pond depressed fracture, rather than the pond depressed fracture is like the dimple produced by squeezing a ping pong ball. Right here is an illustration of some fractures that occur on the skull. You see some fracture lines there. The fracture lines on the maxilla, and some other parts of the facial skeleton. What are the localizing signs in cranial fractures? Fractures of the anterior cranial fossa may involve the frontal bone, ethmoidal and sphenoidal sinuses, So when you have fractures of the anterior cranial fossa, the frontal, ethmoidal, and sphenoidal sinuses may be involved, and such fractures are accompanied by bleeding into the nose or mouth. In such cases, cerebrospinal fluid may leak from the nose, and when you have leakage of cerebrospinal fluid from the nose, it means there is a coexisting tearing of the meninges. In such a case, the subarachnoid space is thus put in communication with the exterior via the nasal cavity. So there is risk of meningitis as infection of the meninges by microorganisms. Fractures involving the roof of the orbit are frequently associated with blood tracking forward beneath the conjunctiva, what we call the subconjunctival hemorrhage. Subconjunctival hemorrhage should be differentiated from a small flame-shaped hemorrhage of the conjunctiva that is caused by direct injury to it. You have a black eye. A black eye is not necessarily due to anterior cranial fossa fracture. A black eye may be produced by direct contusion of the soft tissues, or it may be due to blood tracking down deep to the aponeurotic layer of the scalp. Anterior cranial base fractures may involve the cubiform plate. So in such a case, you will have anosmia, loss of smell, and this is due to rupture of fibers of the olfactory bulb. The anosmia is due to rupture of fibers of the olfactory bulb. So anterior basal cranial base fractures may involve the cubiform plate. It may also involve the optic foramen. So when the optic foramen is involved, you could have primary optic atrophy and blindness. Fractures of the middle cranial fossa may produce bleeding into the mouth. So in such a case, there is involved of the sphenoid bone. The sphenoid bone might be the one that is fractured. So you could also have bleeding or cerebrospinal fluid leakage from the ear, and facial and auditory nerve injury. When there is oral bleeding from the ear, it could be produced. Bleeding from the ear could come as a result of direct injury to the ear, and for example, when there is injury that causes rupture of the eardrum, so it might not only be due to skull fracture. So when there is bleeding from the ear, it might be due to fracture of the middle cranial fossa. It may also be due to direct injury to the ear when that causes rupture of the eardrum. That's the point I'm trying to make. The abducent nerve has a long course. So the abducent nerve may be damaged, and you have diplopia and paralysis of the lateral rectus muscle. Posterior cranial fossa fractures are less often accompanied by cranial nerve involvement. These fractures are suspected when you have bruising over the mastoid region. Such bruising extends downwards over the sternocleidomastoid. Now I must talk about malar flush. The malar bone is the zygomatic bone. The zygomatic bone was once called the malar bone. So when you talk about malar flush, it's a flush, a redness of the skin around the zygomatic bone. So if there is redness of the skin covering the zygomatic prominence, that what we call the malar prominence, we say there is malar flush, and it's associated with a rise in temperature that you see in some fevers occurring in certain conditions, diseases like tuberculosis and systemic lupus erythematosus. Usually in any condition where you have rise in carbon dioxide tension, usually one of the reactions of the body is that there is vasodilation, and the vasodilation, when it occurs in the blood vessels around the malar region, it could cause the redness, that's the malar flush. Now let me talk about fractures of the maxillae and associated bones. Many thanks to Dr. Clement Lefort, a Paris surgeon and gynecologist that classified fractures of the maxillae. Lefort 1 fracture, Lefort 2 fracture, and Lefort 3 fractures could occur. So Lefort 1 fracture is the term that describes wide variety of horizontal fractures of the maxillae that pass superior to the maxillary alveolar process. That is, passes superior to the roots of the teeth, maxillary teeth. Such fracture crosses the bony nasal septum and possibly the pterygoid plates of the sphenoid. What about Lefort 2 fracture? Lefort 2 fracture passes from the posterolateral part of the maxillary sinuses, that's the cavity in the maxillae, the cavities in the maxillae, and when it does so, it goes superiormedially through the infraorbital foramina. It goes through the lacrimals, the ethmoids to the bridge of the nose. So in Lefort 2 fracture, the entire central part of the face, including the hard palate and alveolar processes, is separated from the rest of the cranium. What about Lefort 3 fracture? You could have a depressed comminuted fracture. For the infant skull, ethmoid and nasal bones, it extends laterally through the greater wings of the sphenoid and is frontozygomatic sutures. You could also have concurrent fractures of the zygomatic arches, causing the maxillae and zygomatic bones to separate from the rest of the cranium. So right here you have an illustration of Lefort 1, Lefort 2, and Lefort 3 fractures. You have an anterior view and a lateral view of fractures, the Lefort 1, 2, and 3 fractures illustrated here. Also, you have an illustration of Lefort 1, 2, 3 fractures there. The various bones are colored with various colors. The maxilla is there with a blue color. The lacrimal bone has a purple color. The parietal bone has a light green color, and the various bones have various colors there. Now, fractures of the mandible. A fracture of the mandible usually involves 2 fractures. Frequently, these fractures occur on opposite sides of the mandible. So when you observe one fracture, look out for another. Like when you have a hard blow to the jaw, lower jaw, most times you have fractures of the neck of the mandible and its body in the region of the opposite canine tooth. So the force is transmitted to the opposite side, and that is where you have the fractures occurring. Fractures of the coronoid process are seen less often, and usually such fractures occur singularly. That's, you see the fracture, a coronoid process fracture, as a single fracture. It's usually single. Fractures of the neck of the mandible are commonly seen as transverse fractures, and such fractures may be associated with dislocation of the temporomandibular joints on the same side. Fractures of the angle of the mandible are commonly seen as oblique fractures, and such fractures may involve the bony socket or alveolus of the third molar tooth. Fractures of the body of the mandible commonly pass through the socket of a canine tooth. That may be due to the very long root that the canine tooth has. Right here is an illustration of the mandibular fractures. You could see the fractures. You can see the fractures there. It could be a symphysis fracture, fracture of the body. It could be a condyle fracture. The coronoid process could be affected. Then of course the ramus, could be an angular fracture of the angle, or fracture of the body. You see a lateral view and anterior view of the various fractures. Right here also is some other illustration telling you the frequency, showing the frequency of the various fractures that occur on the mandible. The commonest fracture that occurs is the condylar fracture, and the least common fracture is the fracture involving the ramus. Now, resorption of alveolar bone. When there is extraction of teeth, this causes the alveolar bone to resorb in the affected regions. So when there is complete extraction of maxillary teeth, or there is complete loss of the maxillary teeth, the circuits begin to fill in with bone, and then the alveolar processes begin to resolve. Same thing applies to the mandible. Extraction of mandibular teeth causes the bone, alveolar bone, to resolve. Then with time, the mental foramen lies near the superior border of the mandible, and in very bad cases the mental foramina disappear, and this exposes the mental nerves to injury. So of course, what do you have? Pain. So when in a situation where there is pressure from a dental prosthesis, like a denture that is resting on an exposed mental nerve, of course there will be pain. Such pain is produced each time the individual attempts to eat. When there is loss of all the teeth, what do you have? You have a decrease in the vertical facial dimension, and you have mandibular prognathism, that's there's overclosure. The mandible is prominent, becomes prognatic, overcloses when you attempt to close the mouth. Deep creases in the facial skin are also seen, and this pass posteriorly from the corners of the mouth. Now let me talk about fractures of the Calvaria. The convexity of the Calvaria is good because it distributes and minimizes the effect of a blow to the head. So when there is a hard blow, for example, in thin areas of the Calvaria, such areas are likely to get fractured, and you have depressed fractures there. So you have a bone fragment that is depressed inward, that's a depressed fracture. And when this occurs, what happens? You have an injury of the brain due to compression. The brain is compressed and is injured. So injury of the brain due to compression. You could have linear Calvaria fractures. Linear Calvaria fractures are quite frequent and occur at the point of impact, but you find the fracture lines radiating away from the linear fracture, and they radiate away in two or more directions. You could also have a comminuted fracture. Here the bone is broken into several pieces. When you have an area of the Calvaria that is thick, being affected by an impact or trauma or injury, you find out that the bone may bend inward without fracturing, but the fracture may occur some distance from the site of direct trauma, where the Calvaria is thinner. You have what we call a counterblow fracture. So in a counterblow fracture, no fracture occurs at the point of impact, but one occurs on the opposite side of the cranium. Fracture of the Pterion, how is it like? Fracture of the Pterion could be life-threatening because the Pterion overlies the anterior branches of the middle meningeal vessels, artery and vein. And these vessels lie in grooves on the internal aspect of the lateral wall of the Calvaria. Don't forget that the Pterion is 3 to 4 cm superior to the zygomatic arc, and it also lies posterior to the frontal process of the zygomatic bone. So when there's a hard blow to the side of the head, it may fracture the thin bones that form the Pterion. That's the frontal bone, temporal bone, the parietal bone, and the greater wing of the sphenoid. So these bones may be fractured, and there might be a rupture of the anterior branch of the middle meningeal artery that crosses the Pterion. So you have hematoma resulting, and this hematoma exerts pressure on the underlying cerebral cortex. When there is an untreated middle meningeal arterial hemorrhage, you could have death in a few hours, so it's not a good thing at all. So right here is an illustration of the Pterion, and then when you take a close look, you see what happens when there's a fracture of the Pterion. Age changes in the face. What are the age changes in the face? The mandible is the most dynamic of the bones that we have, because its size and shape and the number of teeth normally undergo some great changes with age. In the newborn, the mandible has two halves, and these two halves are united in the median plane by cartilaginous joint, what we call the mandibular symphysis. Union between the halves of the mandible is by means of the fibrocartilage, and this union begins during the first year, and the halves are fused by the end of the second year. The body of the mandible in newborn infants is a shell, like a shell that lacks an alveolar process. So each half encloses 5 deciduals, that's the primary teeth. These primary teeth usually begin to erupt in infants at about the age of 6 months. The body of the mandible elongates, and you notice this particularly posterior to the mental foramen, and as it elongates, it accommodates the development of the primary and later the 8 permanent, that's the secondary teeth, which begin to erupt during the 6th year of life. Eruption of the permanent teeth is not complete until early adulthood. There is rapid growth of the face, and this is seen during infancy and early childhood, and this is actually the period where you have eruption of deciduals, the primary teeth. Vertical growth of the upper face occurs usually from dentoalveolar development. So the changes that you see in the face are most marked after the permanent teeth erupts. Right here is an illustration of age changes that occur on the face. You see, by your left, you can see the individual when he was much younger, the face. Then by your right, you can see the same individual when he's much older. You can see the face there. Now, obliteration of the cranial sutures. The obliteration of sutures between the bones of the Calvaria usually begins between the ages of 30 and 40 years on the internal surface, and you have like 10 years later the obliteration occurs on the external surface. Obliteration of sutures usually begins at the bregma and continues sequentially in the sagittal, coronal, and lambdoid sutures. Right here you can see an illustration showing the obliteration of cranial sutures. What about age changes in the cranium? You must know that as people age, the cranial bones become progressively thinner and lighter, and the diploid gradually become filled with a gray gelatinous material. Remember, the diploid is the cancellous part of the bones of the skull. In such individuals where you have the cranial bones getting thinner and lighter, and the diploid gradually becoming filled with gray gelatinous material, The bone marrow actually has lost its blood cells and fats, and this gives a gelatinous appearance. So right here is an illustration showing the age changes you find in the cranium. You can see the cranium at the age of a child, and at the age of a neonate, and that of an 8-year-old, and then of course that of a 35-year-old. What about Craniosynostosis and cranial malformations? You could have premature closure of the cranial sutures, that's primary craniosynostosis, and this results in several cranial malformations. The primary craniosynostosis is you find it in 1 per 2,000 births. The cause of craniosynostosis is not known, but genetic factors appear to be very important as far as the etiology of craniosynostosis is concerned. There is the belief that abnormal development of the cranial base creates some kind of huge force, exaggerated forces on the dural matter, that's the outer meningeal covering of the brain, and this disrupts normal cranial sutural development. So these malformations are the cranial malformations that I'm talking about. Craniosynostosis, giving you cranial malformations, are more common in males than in females, and most times they are associated with skeletal anomalies. So the type of malformed cranium that you have depends on which suture closes prematurely. When you have premature closure of the sagittal suture, the anterior frontanel is small or absent. You have a long, narrow, wedge-shaped cranium, and that condition is called scaphocephaly. When there is premature closure of the coronal or lambdoid suture, when you have it occurring on one side only, the cranium is twisted and asymmetrical, and that condition is called plagiocephaly. When there is premature closure of the coronal suture in a high tower-like cranium, it is called oxycephaly or toricephaly. So the case of toricephaly, you have it common in females, and you must note that when there is premature closure of sutures, it usually does not affect brain development. Well, that is some kind of consolation. So right here you have a lateral view and superior view of sutures, the coronal suture, and some of this coronal suture, the lambdoid sutures, and then you see the frontal and anterior frontal and posterior frontal in the infant. So when this close prematurely, you see some malformations like this next diagram showing skull deformities associated with premature closure of the sutures, just like I explained a while ago. Now let me talk about scalp wounds. You have epicranial aponeurosis, which is very common. It's important to us clinically. The epicranial aponeurosis that you find in the scalp is important to us clinically. The strength of this aponeurosis and is quite great. It has great strength, and because of that, superficial scalp wounds do not gape, and the margins of the wounds are held together. So we are happy about that. Then when you have deep sutures, Deep sutures, you don't need to do deep sutures when you are suturing superficial wounds. So when suturing superficial wounds on the skull, you don't need to do deep sutures. Why? Because the epicranial aponeurosis does not allow wide separation of the skin. So we like the epicranial aponeurosis. Deep scalp wounds gape widely when the epicranial aponeurosis is lacerated in the coronal plane, because the pull of the frontal and occipital bellies of the occipital frontalis muscle, which goes in opposite directions, the pull goes in opposite directions anteriorly and posteriorly. So this tends to make the epicranial aponeurosis to give way, and then of course the scalp wounds will now gape in such a situation. So in such a situation, you need to do some deep suturing. What about scalp infections? Scalp infections. The loose connective tissue, that's the fourth layer of the scalp, is actually the danger area of the scalp, because blood or pus spreads easily in it. When there is infection in this layer, the infection can pass into the cranial cavity through emissary veins, and these emissary veins pass through parietal foramina in the Calvaria and reach intracranial structures such as the meninges. So of course the infection can spread. An infection cannot pass into the neck because you have the occipital bellies of the occipital frontalis muscle attached to the occipital bone and mastoid parts of the temporal bones. So thanks to these attachments, it limits the spread of infection to the neck. So scalp infections do not spread to the neck. Scalp infection also cannot spread laterally beyond the zygomatic axis because the epicranial aponeurosis is continuous with the temporal fascia that attaches to these axes. Sebaceous cysts. The ducts or sebaceous glands associated with hair follicles in the scalp may become obstructed. What happens when such ducts are obstructed? You have retention of secretions and there is formation of sebaceous cysts. So the sebaceous cysts are in the skin, and thus the sebaceous cysts move with the scalp. Cephalohematoma. You see cephalohematoma after a difficult case of childbirth. Bleeding occurs between the baby's pericranium and calvaria, usually over one parietal bone. Blood becomes trapped in this area, causing a cephalohematoma. And you could have actually, when there is birth trauma, there could be rupture of multiple tiny periosteal arteries that nourish the bones of the calvaria. Now, bone flaps. What about bone flaps? Bone flaps may be needed because the adult pericranium has poor osteogenic, that's bone forming properties. So little regeneration occurs after bone loss. So when pieces of bones are removed during repair of a comminuted cranial fracture, for example, there might be need to make use of surgically produced bone flaps that are put back into place and wired to other parts of the calvaria. Occlusion of cerebral veins and dural venous sinuses may result from thrombi, that's blood clots. Thrombi, blood clots. Occlusion of cerebral veins and dural venous sinuses may also result from thrombophlebitis, that's venous inflammation. It could also result from tumors like meningiomas. The dural sinuses that are most thrombosed are the transverse, cavernous, and superior sagittal sinuses. The facial vein has an important clinical connection with the cavernous sinus via the superior ophthalmic vein. So cavernous sinus thrombosis. Cavernous sinus thrombosis usually results from infections in the orbit, nasal sinuses, and superior part of the face, what we call the danger area. So in persons with thrombophlebitis of the facial vein, pieces of an infected thrombus may enter into the cavernous sinus, and this causes thrombophlebitis of the cavernous sinus. The infection usually involves only one sinus at first, but may spread to the opposite side through the intercavernous sinuses. Thrombophlebitis of the cavernous sinus may affect the abducent nerve as it traverses the sinus. It may also affect the nerves embedded within the lateral wall of the sinus. Septic thrombosis of the cavernous sinus results in development of acute meningitis. Right here is an illustration of the sinuses, the dural venous sinuses, and the cerebral vein. This is some other illustration of the dural venous sinuses. Now, metastasis of tumor cells to the dural sinuses. Remember that the basilar and occipital sinuses communicate through the foramen magnum with the internal vertebral venous plexuses. So because of these venous channels, which are valveless, these venous channels are valveless, so compression of the thorax, abdomen, or pelvis that occurs during heavy coughing and straining may force venous blood from these regions into the internal vertebral venous system, and from there the blood goes to the dural venous sinuses. So what happens as you now have pus and abscesses and the tumor cells from the thoracic region, the abdomen and pelvis, spreading to the vertebrae and brain. Now the fractures of the cranial base. When there is fracture of the cranial base, the internal carotid artery may be torn, producing an arteriovenous fistula within the sinus. Arterial blood rushes into the cavernous sinus. This makes the cavernous sinus to be enlarged and forces retrograde blood flow to the venous tributaries, especially the ophthalmic vein. So you now have the eyeball protruding, what we call exophthalmos, and the conjunctiva becoming engorged, what we call chemosis. The protruding eyeball pulsates in synchrony with the radial pulse, and we call this pulsating exophthalmos. Then note that the cranial nerve 3, 4, 5, and 6 lie in or close to the lateral wall of the cavernous sinus, so these nerves may also be affected when the sinus is injured. Right here is an illustration of the fractures of the cranial base. Cerebral injuries. You have cerebral concussion as an abrupt, brief loss of consciousness immediately after a head injury. So consciousness may be lost for 8 to 10 seconds briefly, and like you see in a boxing competition. When there is severe injury, like from auto crash, consciousness may be lost for hours and even days. If the person recovers consciousness within 6 hours, it's a good case. But if the loss of consciousness stays longer than 6 hours, brain tissue usually most likely is injured. Boxers are at risk of suffering from chronic traumatic encephalopathy, what we call the punch drunk syndrome. So in that case, you have brain injury characterized by weakness in the lower limbs, unsteady gait, slowness of muscular movements, tremors of the hands, hesitancy of speech, and slow cerebration, that's the use of one's brain. The injuries actually result from acceleration and deceleration of the head. There is cerebral contusion, that a case that can result from brain trauma. In cerebral contusion, there is brain trauma, and in that case, a pear is stripped from the injured surface of the brain and may be torn, and this allows blood to enter the subarachnoid space. The bruising results either from sudden impact of the brain against a still moving brain against the stationary cranium, or it could be from sudden impact of a moving cranium against the stationary brain. Cerebral contusion may result in an extended loss of consciousness, but usually there's no diffuse axonal injury. There is no brain swelling or secondary hemorrhage, and recovery from cerebral contusion is actually good. Cerebral lacerations are often associated with depressed cranial fractures or gunshot wounds. Cerebral lacerations result in rupture of blood vessels and bleeding into the brain and subarachnoid space. This causes increased intracranial pressure and cerebral compression. Note that cerebral compression may be produced by intracranial collection of blood, obstruction of cerebrospinal fluid circulation or absorption, intracranial tumors or abscesses, brain swelling caused by brain edema, that's an increase in brain volume resulting from an increase in water and sodium content. Permit me to talk about hydrocephalus. Hydrocephalus is overproduction of cerebrospinal fluid or obstruction of cerebrospinal fluid flow or interference with cerebrospinal fluid absorption. So all these result in excess fluid, cerebrospinal fluid, in the cerebral ventricles, and there is enlargement of the head. That is what we call, the condition is called obstructive hydrocephalus. The excess cerebrospinal fluid dilates the ventricles. It also makes the cerebral cortex thin and separates the bones of the Calvaria in infants. Although an obstruction can occur at any time, the blockage usually occurs in the cerebral aqueducts, that's the interventricular foramen. Aqueductal stenosis, that's narrowing of the aqueduct, may be caused by a nearby tumor in the midbrain. Could also be caused by cellular debris. Such cellular debris could come as a result of intraventricular hemorrhage or bacterial and fungal infections of the central nervous system. Blockage of cerebrospinal fluid circulation results in dilation of the ventricles superior to the point of obstruction, and there is pressure in the cerebral hemispheres. This squeezes the brain between the ventricular fluid and the Calvaria bones. In infants, the internal pressure results in expansion of the brain and Calvaria because the sutures and frontanels are still open. So you could have an artificial drainage system to bypass the blockage and allow CSF to escape, and this lessens the damage to the brain. When there is communicating hydrocephalus, the flow of cerebrospinal fluid through the ventricles and into the subarachnoid space is not impaired, but movement of cerebrospinal fluid from this space into the venous system is partially or completely blocked. The blockage may be caused by a congenital absence of arachnoid granulations, or the granulations may be blocked by red blood cells as a result of subarachnoid hemorrhage. What about leakage of cerebrospinal fluid? Fractures in the floor of the middle cranial fossa may result in cerebrospinal fluid leakage from the external acoustic meatus, what we call cerebrospinal fluid arteria. If the meninges superior to the middle ear are torn and the tympanic membrane is ruptured, you will have CSF, cerebrospinal fluid arteria. Fractures in the floor of the anterior cranial fossa may involve the cribriform plate of the ethmoid, and this results in cerebrospinal fluid leakage through the nose, what we call cerebrospinal fluid rhinorrhea. Cerebrospinal fluid can be distinguished from mucus by testing its glucose level. The glucose level of cerebrospinal fluid reflects that of the blood. Cerebrospinal fluid otorrhea and rhinorrhea may be the primary indications of a cranial base fracture. So when you see cerebrospinal fluid otorrhea and rhinorrhea, you suspect that there is cranial base fracture, and they increase the risk of meningitis because an infection can spread to the meninges from the ear or nose. Thank you so much for listening. Don't forget to subscribe to this channel. Goodbye for now.